Hi, everybody. Welcome. Thank you very much for joining us today. My name is Margaret Koval, and I'm sharing the screen with Dr. Céline Gounder from the class of 1997. Hi, Céline.
Hi, how are you?
Thank you. Thank you. I'm Director of Special Projects at the Office of Communications at Princeton, and also producer of the podcast We Roar, which we started back in March when coronavirus first kind of blasted into all of our lives, knocking everything off the table. We did it to maintain community at first, but also to hear innovative and unexpected perspectives from members of the Princeton community from all walks of life. People who are working on solutions, people who have interesting experiences, and so on. So we've done 21 episodes so far, and I hope you will go to our website and subscribe. And our 22nd is with Dr. Gounder, which is a fortuitous event because so much has happened that we want to turn somebody with Céline's expertise. Céline is a specialist in infectious disease. She studied Ebola, studied and been on the ground in I think, Guinea, is that right?
Mm-hmm. Mm-hmm.
Working on Ebola, HIV in South Africa, and tuberculosis. She's an attending physician at Bellevue Hospital in New York. And she's also a medical journalist who's been doing a fabulous job spreading information to the general public. So you'll get a chance to ask Céline your questions in a few minutes. Put them in the comment lines on Facebook. And in the meantime, let's listen to the podcast that she recorded with us back in May together.
I'm Dr. Céline Gounder. I was class of 1997 at Princeton. I am the host and producer of the podcasts EPIDEMIC and American Diagnosis, and I am a CNN medical analyst. I think the COVID pandemic really lays bare how even people like me who have studied these epidemics and pandemics, have experienced them on the front lines, how even we can be taken off guard and how quickly the situation can evolve and how quickly you have to adapt to that. Many of us were hoping this was going to be like SARS, so largely contained in the regions where the virus emerged. But I know by January, I had realized this was going to be a much bigger deal because by January, I was on the wards at Bellevue teaching my medical students and residents about the virus, telling them about the latest science, and saying to them, you got to get yourselves ready and learn about this because we're going to see this in the US before too long. There was sort of a little bit of rolling the eyes and kind of like, oh, this is esoteric stuff that's not really relevant to us. We should be talking about the regular heart attacks and pneumonia kind of stuff. And I can say in February, I was concerned that people just weren't taking it seriously. It was sort of this, oh, it's over there in that part of the world. It's not going to happen here. It was this denial mentality. And I think there is something to be said for having lived through some of these things before, traveling to West Africa to work on Ebola, traveling to South Africa and other parts of sub-Saharan Africa to work on tuberculosis and HIV. I've experienced these things in other countries, in other settings. And I think that there's also a certain pattern recognition that you start to develop. And I think part of that pattern recognition is with respect to the diseases and the science, but part of the pattern recognition is also with respect to human behavior and politics. And seeing some of those exact same things play out, for example, during the Ebola epidemic and how there was sort of a parallel epidemic of conspiracy theories and rumors and false information in West Africa. And we were seeing and we still are, seeing the exact same thing here. At the time, we had this attitude of, oh, those are primitive, superstitious people. It's not that they were primitive, superstitious people. It's that they're human. And that's sort of how human psychology is. That's how we respond in situations we're afraid, we're stressed, you're having to weigh different competing priorities. There's a lack of information. And so rumors sort of sprout up where there's a lack of information and lack of transparency. I think very often in these situations, it's a question of political will. By that, I mean, do you start with the science? Do you start with a scientific approach? Do you start by asking questions, testing hypotheses, evaluating them and figuring out what works and moving from there? Or do you start with, this is what I want, and I'm going to rationalize what I want? And I think, unfortunately, the latter is what you've been seeing. And I think that pattern is not unique to us. It's something you see happen over and over again over time and in different places. And so that's really frustrating to see that happen. I think this is a moment in which doctors and public health practitioners and others, scientists, really should be involved in these public debates. I think we have a responsibility to be involved in those debates. And I think what's unfortunate is we wasted a lot of time debating whether this was real, whether this was a problem that needed to be addressed in a significant way. This, again, harkens back to Ebola. The discussion there was, is Ebola a hoax or is it real? And we had the exact same conversation here about COVID. Well, I have worked in a number of different media. When you go on television, you get maybe 3 to 5 minutes. You answer questions with an anchor, and you have less influence over what the content is. You have to start at a fairly basic level in answering a question. And so it's really very much bullet points. And so part of what I like about podcasting, it allows you to get to know somebody. There's a lot of emotion and sort of worldview, in a sense, that gets communicated through someone's voice and how they speak. And then also with podcasting, because traditionally that's been something people have listened to on their commute to and from work, that gives you, in general, a bit longer of a period of time to tell a story. You have more space because the average commute is somewhere around 20, 30 minutes. So in 20 or 30 minutes, you actually have a good amount of time to get into a more nuanced, detailed story. And so I think, for example, there's been a lot in the news about antibodies and antibody testing, but there's also been a lot in the news about vaccines that are in development. And so trying to sort of communicate, how does the immune system work? And are antibodies the end-all be-all? And why might some vaccines work better than others depending on the kind of virus? That gets to be pretty complicated to explain something like that in 3 minutes on television. But to do that in a podcast, you can get into that science so that people understand the bigger picture and they have a better understanding of some of these news headlines. Had we really been prepared back in January, we would have been looking for cases arriving here. We didn't do that. Once there was so much community transmission in many parts of the country, we had put ourselves in a position where we really had no choice but to implement shelter in place and lockdown kinds of measures. The problem is that during that lockdown period, we didn't do what we needed to do to scale up testing. We didn't hire the contact tracers. We didn't develop the data management tools and systems. And so, yes, I think we're all anxious for life to go back to normal, for the economy to reboot. But we had a lot of work to do in the interim, and we didn't do it in many parts of the country. And I think that's really unfortunate. If you go back and you look at the data from the Spanish flu, there's some really interesting comparisons of different cities and their approaches. And the cities that waited too long to implement their lockdowns, that lifted too quickly, are the cities that then would have an even bigger second wave than their first wave. And I'm really hoping that's not going to happen with coronavirus. It is, after all, a different virus, but that is very concerning. And I'm still very worried that we haven't done the work that we need to do to control the virus, with the exception of using these very blunt tools like lockdowns. I think the question is, how do you convince people that preparing for a biological, medical, public health threat is just as important as preparing for a military or terrorist threat? And I think all of these are national security threats. I think big picture, they're low probability but high threat, and do require us to invest and prepare because of the potential catastrophic nature of those threats, even if year to year they're low probability. And I think, unfortunately, we're very short term in our thinking about public investment and public policy of all kinds, not just this kind. I'm just hopeful that maybe as we live through this, that the importance of that kind of preparedness is recognized and that we do start to reinvest in public health systems and into preparedness of all kinds.
Well, thank you very much for that, Céline. And once again, that was recorded back in mid-May. Some of the things that you said in there, though, seem right on topic for today. We've obviously passed that kind of tragic milestone, over 100,000 deaths in this country. And even still, many states are beginning to reopen. So my first question, while we collect audience questions, again, please write them in the comments section. I'm going to kick it off by asking you, Céline, we've seen some spikes recently in states like Florida, South Carolina. I'm wondering, given what you said in your podcast, what can you tell us about these spikes? What do you think is causing them? And how could we have avoided that?
Well, I think it's important to remember that the shelter-in-place orders, lockdowns, whatever you want to call them, they're not cures, they're not vaccines, they don't eradicate the virus. They suppress the virus. It's sort of like you're playing hide and seek with the virus. And as soon as you come out of hiding, it's still there. And of course, transmission is going to start up again. And so really what the strategy, many of us have been saying all along was while you have these shelter in place orders, that's buying you time, while you're suppressing transmission to do the things that allow you to return to at least some sort of normalcy while still continuing to keep the virus contained. And so that's all about the testing, the contact tracing, what do you do with somebody who's infected so that you can isolate them from others? We didn't do that. And, I get that people got very impatient about the, basically halting of the economy during that period and got very frustrated. It had a massive damaging impact on the economy. My husband's actually one of the people who lost his job during that. So I know very well the impact. And, I think the problem is it's sort of like a child in the back seat on a long family car trip. Are we there yet? Are we there yet? Are we there yet? And saying, are we there yet is frankly childish. There was work to be done. We're not children in the back seat. And so then you see states reopening without the pieces in place that needed to be in place to do it safely. And of course, the virus is still there. This is completely predictable that you would start to see transmission reboot. And then there's been this discussion, is this a first wave? Is this a second wave? This is the first wave because it never fully was suppressed in many of these places. So this is just sort of, you saw a little bit of a dip and then a rise again. And when we talk about second wave, we're really talking about probably next fall, which will be in conjunction with flu season.
Yeah, I guess the other thing that's happened since you and I first spoke is the rise in street protests for racial justice after the killing of George Floyd. Everybody seems fatigued with the lockdown. Everybody wants to get out. I wonder what you think those protests what impact those protests will have on the virus, and maybe talk a little bit too about some of the safety issues involved in protesting, should people want to be doing that.
Yeah, I do think it's important to distinguish between different protests and different activities. So we had protests actually earlier on, maybe March, April, about the lockdowns, and those protests, some of them were indoors in state houses, so that's a very different level of risk. And by and large, those protesters were not wearing masks. And so that's also a very different level of risk. The recent protests over George Floyd, in fact, people were using the masks to signal something, in text on their mask, which is sort of clever. But by and large, most people were wearing masks, and those were all outdoor protests. So there are different levels of risk with each of those. That said, I personally did not march in the streets. It's probably one of the first protests I have not attended in my adult life, of that size. And I personally have responsibilities to my colleagues at Bellevue. If I get sick, it means I can't attend and take care of COVID patients who are in the hospital right now. So for me, there's a real trade-off between the two in terms of my work responsibilities and what are my, what I'd like to do in my personal life. So it's a little bit different also of a decision for me. That said, I think what COVID has really laid bare is that who's getting infected with COVID, who's dying from COVID. This is really about vulnerabilities that have been there in our system all along. And I'll just give you sort of two very concrete examples, because I think very often words like structural racism are thrown around and people don't really know what that means. So I'll give you two examples which directly relate to COVID. So one is back in the 1930s, FDR signed into law the National Labor Relations Act. And that was really instituting, among other things, labor and safety, health and safety protections for workers. Now, what were the two major classes of workers left out of that law? So that was agricultural workers and domestic workers. And why? Because those were largely people who were Black. And that was a compromise with Southern lawmakers to say, okay, fine, you can keep your Black workers without those protections and drive up your costs, but everybody else gets those protections. So that's a very clear thing that's playing out now, where you see caregivers working in nursing homes or in the home. You see people working in agriculture, for example, in meatpacking plants. There's a reason they're at extremely high risk for infection. They simply are not protected in the same way. And then another example that I would say is in some ways a more recent example has to do with health insurance coverage. Well, we're a country where we tie health insurance to jobs, but not any job. They're largely, quote unquote, good jobs, white jobs. And then you have with LBJ, the signing in of Medicare, Medicaid, which were extremely controversial at the time. A big part of the civil rights platform was actually advocating for universal health care. And there was a separate African-American Doctors Association that was advocating for that, while the AMA was strongly opposed. The passage of Medicare and the way that funded hospitals also was very influential in desegregating many health facilities, at least to some degree. And Medicaid has always been this ugly stepchild where people feel like, well, that's for undeserving people. Never mind that it's actually paying for health, or covering health insurance for people whose jobs don't provide it, like Walmart. And even today, many states have still not expanded Medicaid the way they could under the Affordable Care Act. And those are largely, again, former slave states. So now you have people who are getting sick with COVID who don't have access to health care. And this is completely tied to things that are baked into our laws and institutions. So, if they go out and protest about racism, to me, that's very much tied to the current coronavirus pandemic. You really cannot separate those two issues. And frankly, what I would say to those who are upset that they're protesting, these are issues that should have been addressed before, and then they wouldn't need to be protesting.
I'd like to come back, if we get time, to talk more about how to safely protest and drill in some of the other areas that you will and won't do as a personal expert in all of this. But I'm going to take a couple of questions from our Facebook listeners. I've got one from Sabrina S. about antibody testing. She's wondering if we should be taking these antibody tests now, or should we wait for more reliable tests or until more is known about the COVID-19 antibodies? Yeah,
and actually I would refer you to a recent podcast episode of Epidemic. We did delve into some of that science, but the short answer to that is, one, the antibody tests are not great, and two, we're not quite sure what they indicate. So to drill down onto that further, there's some issues with sensitivity and specificity, especially specificity. So meaning you're going to get some false positives, and we're not quite sure what to make of those test results. So that might give somebody the impression that they are immune or protected, and they're not. The bigger issue, though, is that we're not sure what part of the immune system really protects you here. So we do know people develop some level of immunity after a coronavirus infection, but with other coronaviruses, it's not that long. It's on the order of 1 to 3 years. So it's not very long, first of all. And second of all, there are different parts of the immune system. You have antibodies, you have T cells. To give you an analogy with another infectious disease, HIV, if you test antibody positive, you're not immune to HIV. You have HIV.
Right.
And so it's really important to figure out which arm of the immune system is actually important here. And that also, it's not just about testing, it's also about how do we design a vaccine? Which part of the immune system do you want the vaccine to be stimulating? And this is a great example of where the vaccine, there's been this debate among the anti-vaxxer community. Oh, well, isn't it better to have the natural infection? Well, not necessarily. This may be a very good example, in terms of how can you best generate the strongest immune response? It may not be the natural infection. It may be what you're able to design a vaccine to do that doesn't happen naturally.
So just what I'm hearing, I think, is that you have a very limited trust in these tests right now, and wouldn't advise anybody to take solace in a positive antibody test and then go out and think that they were immune.
I think if you have a positive antibody test, it probably means you were exposed, infected, but I would not take that to mean you're immune and protected. I would still continue to take all the same precautions. And I'll give you an example. At Bellevue Hospital, they are offering, if you want it, antibody testing, and I've had it. I came back negative, but had I come back positive, I would still be putting the same protective gear on, because I know that doesn't mean I'm protected. And the reason they're offering that testing at the hospital is not to figure out who's immune and who's not. It's really to figure out which classes of workers were most highly exposed and how we can change our practices to protect those people better. So for example, nurses versus doctors, or, in the emergency room versus the operating room, who needs better protection than they were already getting. It's not about immunity.
Huh, interesting. We have another, I think a lot of people are asking questions, big, very practical questions. So I hope you have an appetite. From Mark G, what is the utility of monitoring body temperature before allowing somebody to enter a store or school or airplane, obviously? And he asks also if there's any historical evidence of using temperature monitoring to stop or arrest the spread of epidemics.
Yeah, this has been used with some airport screening with prior pandemic flu, for example, SARS. With Ebola, it's not highly sensitive is the problem. So for example, and they were doing this at the hospital as well. So all of us coming into work, and it's only people who work at the hospital or our patients who have been allowed, visitors have not been allowed. And so you would queue up 6 feet apart, and somebody would take your temperature as you're coming into the building. But after walking half an hour across Manhattan in the cold, I show up as hypothermic. In other words, I show up as too low. Or on a day, say it's 90 degrees and you walk to work, similarly, you may show up as too high. So unfortunately, those instruments are highly dependent on how they're used, in what setting, how you're screening people and when. So it's helpful to some degree if you know a little bit more the context of the person that you're screening, but you're going to have a lot of missed cases probably that way.
On another line, a similar line, I should say, Ram K asks if there's a relationship between COVID-19 and hot temperatures during the summer. Again, we're reopening, summer is hitting. Does this give us any security?
Well, it's less about the virus itself. It's more about human behavior. So during the summer months, we spend a lot more time outside, and we do know that your risk of transmission outside of any respiratory virus is lower. And so that's why cough and cold season tends to be, flu season is the fall and winter, not the spring and summer months. It's a reflection of when people are outside versus crowded inside.
I'm going to throw one more at you right now. This I think is tilting towards the recent WHO comment about asymptomatic transmission. This is from Barb M. If there is another spike, what's the source of new cases, she asks. Could it be asymptomatic transmission?
Well, I think unfortunately the WHO, which has said it's trying to fight the infodemic, information epidemic, has contributed to that.
with rather unclear messaging on that point. And I think it comes down to how do we define things as research scientists in a study versus how the average person interprets some of these things. And so I think for the average person, I don't have symptoms right now means I am asymptomatic. It doesn't mean, you know, that person may in 6 hours develop symptoms, but at the time that they reported that, they were asymptomatic. And so, and the other problem with some of those terms is that what some people think is no symptoms, what we've seen is people are not reporting symptoms that they think are associated with COVID, but maybe they have, I don't know, a runny nose and they're sneezing, or they have diarrhea, which are less typical symptoms, but that doesn't mean they have no symptoms, right? So, you know, I think the bigger picture thing, the way to think about this is just because you don't have obvious symptoms of COVID does not mean you don't have it and you couldn't be infectious. And we've seen in various different settings, anywhere from like 35%. So this is a homeless shelter in Boston where they had an outbreak. 35% of cases said they had no symptoms, up to 80% in India. In Iceland, they found something in between, 50%. So we know for sure a big chunk of the transmission is occurring among people who did not have symptoms at the time. Probably our best guess is somewhere between 1/3 and 50%. And some of what we're seeing is that a day or two before people develop symptoms is actually when they're most infectious, as well as the first couple days of symptoms. And that's based on a study that was done at a nursing home in the Seattle area, where they had an employee who was known to have COVID, who had symptoms. And so they knew that the people in the nursing home had been exposed. And so they started doing serial symptom screening and testing. And so we're able to document that, yes, indeed, people were testing positive before and were infectious before they had symptoms. So, you know, I think part of what you're seeing, you're asking, well, where is the spike coming from? The spike is coming from the fact that transmission was happening all along. The cases never went to zero. And we never did the kind of lockdown that China did, which was extreme, you know, much more extreme than what we did. We did something very loose. And so we brought cases down a little bit, you know, and in places like New York dramatically, but there were still cases. And so once you start to lift social distancing restrictions, those cases continue to transmit onward. And, you know, again, the people who don't even realize that they have it are big vectors of that.
Again, this brings up in my mind another topic that's been running through this whole reporting on the pandemic, and that is, you know, not only does the public have to come to terms with this virus, but we have to come to terms with science happening in real time, because we're rushing studies out for obvious reasons. Often they're not peer reviewed anymore, right? In an effort to have transparency and speed, there's studies being quoted all over the place, and there have been a big range of sometimes contradictory recommendations coming out. Again, as a scientist, as a doctor, and as a communicator, how do you feel about that, or how do you weigh those
yeah
things?
I mean, this is where I really don't like media reporting on the study of the day. I'm a big fan, and this is probably why I also like podcasting, is of what I would call slow journalism, where you allow a bit of the data to come in, you have a sense of what different studies say, you have a chance to sort of synthesize that information and figure out what it all means. And I think that's very hard to do when you have, you know, study after study coming and there's so much appetite for what the latest one says. I was recently interviewing Ed Young for the podcast. So he's a science reporter for The Atlantic. He's one of the science reporters I really do respect. And there's, I'll admit, there are not that many I really do follow myself. But for the reasons I just mentioned in part. But I really love Ed, and he had this great comment. He said, science is oscillatory. And you kind of oscillate around the truth and slowly converge on what the truth is. But, you know, that takes time, and it also requires a bit of an understanding of the scientific process, which is you don't decide. And I think this is also a difference between how lawyers and scientists think. You know, lawyers start with, this is the truth, how do I prove it? We start with a question, and we keep asking questions and throwing out ideas and testing those ideas, finally converging on what we think is the truth. And I think that's also a very different mode of thinking than the media approaches things with. So it is a challenge to communicate that stuff.
Yeah, and I'm sure that makes it a very interesting straddle that you're doing between public communications and on the ground research and medicine. This is another question from the audience from Surin. I hope I'm saying the name right. Surin J, class of 19. To what extent is the current infrastructure work done to combat coronavirus applicable for future new infectious diseases? And by infrastructure, I trust he means systems and so forth.
Well, I'm sure surveillance is a big part of what he's talking about. And it's funny, when you said class of 19, for a second, I did a double take. I was like, wow, there's still alumni of that age. And then I realized 2019. Yeah, so surveillance is a major problem. So over the last couple decades, but especially since the Great Recession of 2008, 2009, public health departments have been decimated. We've lost about 50,000 public health workers in that time across the country. I served as Assistant Commissioner of Health in New York City here at the Department of Health. And part of the reason I left that job was because it became very clear to me that it was basically going to be a job of firing huge proportions of the staff and really stripping it down in a way that I didn't feel comfortable with. And I think, unfortunately, that's going to take time to rebuild that kind of capacity. So I think you have a couple pieces here. One is rebuilding the people capacity. I think the hiring that's happening for contact tracing is an important opportunity to do some of that rebuilding. Unfortunately, very specific places. So New York is one of them, California, and it's not surprising which states are really making an effort to rebuild that capacity and hire droves of contact tracers. But that's one major piece. The other piece is how do you conduct surveillance? And that's also a question of laboratory capacity, and it's really IT capacity. And so these are things that have not really been invested in. If you saw the IT infrastructure for a Department of Health, it's pretty rudimentary, relative to what you see in other industries. And that is something that needs to be invested in and needs to be seen as a priority. And it unfortunately hasn't been and still isn't.
Well, it speaks right to the point you made in the podcast, is somehow we have to convince the public that health emergencies are national security emergencies, which need the same sort of advanced planning. I've got another question from Gregory V. He doesn't give his school year. Why are some people in such denial about how pervasive the virus is? I think this is a complex question, but I'm throwing it to you because you just did on your own podcast on Epidemic, an episode about the psychology of pandemics. So what do you think about that?
Yeah, I think, well, there's a number of reasons for that. I think there is a component of some people will not believe it if they don't see it for themselves. And I think in part because this hit the big coastal cities first, that was part of the problem, because it's hitting certain marginalized communities especially hard. That makes it less visible to certain people. And I think the other piece of it is really very much about partisan politics. And it's really a question of showing your support for your political party and tribe first, and then you decide what you believe after. And, I think, unfortunately, the fact that the coronavirus hit coastal cities first feeds into that, right? Because those tend to be more democratic. Places that are being hit later now are more red state, and the concentration or the degree to which marginalized communities are going to be hit there, already being hit there, is also even more skewed than what we've seen in some other places like New York. And so I think, unfortunately, it's a combination of really signaling your loyalty to your group, being part of that group, and then what do you in your very day-to-day life experience? And unfortunately, by the time some of these people experience it, you're sort of many steps behind in terms of what needs to be done to control it.
Yeah. Well, I want to ask you one more question, because we've committed to a certain time limit here, and that is going back to those protests. I wonder if you can talk a little bit about how to protest safely.
Yeah. So a few things. So one, You definitely want to be wearing comfortable clothing, protective clothing. So I would say wear long sleeves, long pants. That's partly to protect yourself from the sun, as well as from, unfortunately, chemical exposures like tear gas. You want to be wearing goggles, ideally not contacts, not your regular glasses if possible, but maybe goggles on top of your glasses to really provide good eye protection. Again, that's to protect you from things like chemicals, as well as other droplets that you may have in the atmosphere. You definitely want to be wearing a mask. Bring plenty of water. Bring a bandana to soak with water, again, if you have a chemical exposure. You don't want to be wearing oil-based sunscreens or lotions, because those can also trap those kinds of chemicals to the skin. One thing that is useful for that kind of thing is baby shampoo, in terms of trying to rinse off some of those chemicals. Be sure to have a buddy with you. You don't want to be doing these things alone in case one of you gets sick or one of you has an issue with the police or some sort of assault, unfortunately. So it's helpful to have somebody with you. Don't wear jewelry. Trying to think what else I might throw in there. Those are probably the most important things. Water, some snacks, probably a good thing. You may not be able to get out of there to get food easily. Yeah, those would be the big things.
Yeah, thank you. That's really, many of those I've never heard before. So thank you very, very much. Mm-hmm. And to the audience, you can hear Céline on her podcast, EPIDEMIC. I assume that's on all the usual podcast distributing apps. And I'm sorry, Céline, you'll have to remind me the title of the other podcast.
So the first one, the original one, is American Diagnosis. So season 1 was on youth and mental health. Season 2 was on the opioid overdose crisis. Season 3 was on gun violence in the US. And season 4 will be coming out in the fall. But we will have a special bonus episode coming out in a couple weeks, just to keep people engaged.
Fantastic. And for anybody who wants to hear more of these bite-sized We Roar podcasts, please go to our website and subscribe. That's weroar.princeton.edu. And of course, we are also on all of the usual podcast distribution apps. So do go there. Thank you so very much for joining us. And we hope we'll do this again.
Yeah, my pleasure. Stay safe, everyone.